Hello, this is Aaron Timms. I am an MS4 at Boonshoft School of Medicine, class of 2024, and I have an interest in pathology. Today, we're going to talk about an overview of thyroid fine needle aspiration and how we use ultrasound and cytology to help guide our diagnosis of thyroid disease. So, first off, most broadly, what is thyroid fine needle aspiration? This technique is used to obtain cytological samples from a thyroid nodule that's noted on palpation or on ultrasound. Sometimes when you're doing an ultrasound for something else, perhaps to check the patency of the lumen of the carotid, you might notice an incidentalloma, some nodule or something. And when you see that, you should really start moving towards diagnosing what's going on. With fine needle aspiration, the benefit of it is a minimally invasive technique, which is, it's also distinct from core needle biopsy. They both are kind of the same when you watch them, but the primary difference is core needle biopsy is a much bigger hole that it generates, and anytime you do that, you do increase the likelihood of damaging structures around the targeted tissue, not to mention increasing infection risk as well. This technique is helpful for diagnostics, evaluation for malignancy, as well as triage to surgery. In many countries and institutions do it differently, but most broadly, this technique can be performed by clinicians like endocrinologists or head and neck surgeons, or procedural radiologists or cytopathologists. I actually had the opportunity to see it done by both procedural radiologists and a cytopathologist, and the techniques that are used are very similar but interestingly different. So if you have the opportunity to see that, I would recommend it. The great thing about Thyroid FNA is it does have an incredibly high sensitivity as well as a great specificity, up to 100% and 94% respectively. So this really gets you what you need to know for the most part. It is a highly accurate diagnostic tool with a low rate of complications, and that's what we love to see. You can see part of it right here. After the aspirate is already collected, it's put on a slide and then assessed cytologically. There are two grading systems, three if you want to think about another one, that wind up playing a role in thyroid fine needle aspiration. One I don't have pictured here is the ATA. I think that's the American Thyroid Association, has their own grading system. But honestly, it's very similar to the American College of Radiology's TIRADS, except for TIRADS is a lot easier to use. ATAs, in my opinion, basically just says look out for all of this stuff and good luck. But TIRADS actually gives you a different categories that you're specifically looking for, keeps it simple down to 5. You still want to keep some things in mind that aren't listed on TIRADS, such as is there Doppler flow within the lesion? And there are some other things as well. But for the most part, TIRADS is really going to serve you well for the ultrasound portion of the fine needle aspiration. As far as cytology is then concerned, there is the Bethesda system, and I have a picture that they include in one of their papers here. Later on, I'm going to show you another one that I have put together from two different papers that I feel is a lot more helpful because it includes more of the information that they discuss in their report. But suffice to say, you get diagnostic categories based on what you're seeing under the microscope, and it tells you a lot of information, including how concerning is this for malignancy, so you can communicate that to the patient, and how should this be managed from here on out. So what I want to do next is look at the typical workflow for fine needle aspiration. And where this really starts is in the clinician's exam room. starts with everything that we've been learning at BSOM, your history, physical exam, initial labs, that kind of thing. So what symptoms is the patient showing? Do we see intolerance to cold, intolerance to heat? Is there any kind of periorbital edema? How's their heart rate? All of this. Do they have a family history of thyroid cancer, or a personal history of irradiation or various thyroid cancer syndromes like MEN2? Do they have hoarseness or difficulty swallowing? Sometimes you can have that from the mass effect of the tumor itself pushing on the trachea. And then also, as I mentioned previously, that history of incidentaloma. Was something seen in other imaging that should be investigated further? Moving on to the physical exam, you might see a goiter. You might feel palpable nodules while you're palpating the thyroid. And then you need to note whether it is tender or non-tender, because typically the cancerous thyroid nodules will wind up being non-tender, while more of a inflammatory syndrome or perhaps autoimmune, it winds up being more tender. At this point, labs are often drawn, and helpfully so. We need to look to see thyroid function, and an elevated TSH can tell us a lot because it's an independent risk factor for cancer. Honestly, when you look at UpToDate's algorithm for how to address thyroid nodules, you wind up seeing that one of the first things after you collect this history and physical exam that starts putting you in this direction of suspicion is the TSH normal or elevated? If so, move right on down and see what you need to do with as far as sonography or ultrasound. In the case that it is low TSH, then you move on to something called scintigraphy, which is essentially seeing how much uptake there is in the thyroid nodule itself. If it's hot, that tells you that it is active and it puts you in one direction. But if it's a cold nodule, if it's really not uptaking anything, then that does still have the concern for cancer, and so you continue on towards fine needle aspiration. So at this point, you would go ahead and get your thyroid ultrasound. Sometimes this is done by a cytopathologist that enjoys patient interaction and wants to have that opportunity to make that connection with their patient. And at other times, it is done by a rad tech or a radiologist. But you're really, the radiologist or that cytopathologist winds up looking for a few things that we kind of briefly touched on with TIRADS, and I'm going to get into right after this. But you're looking for the composition. Is it cystic or solid? The echogenicity. This is, when you're thinking of ultrasound, everything is different shades of gray. If it's a darker color but not black, then it's hypo. If it's the same color, it's iso. And if it is, I have hypo a second time there, but if it is a brighter color, then it's hyperechoic. And all of these can mean different things, different concerning levels, which again I'll address momentarily. The shape then is considered, especially if it is taller than it is wide, then that's actually concerning for malignancy. The margin itself, just like we would consider with skin cancers, if there is smooth borders, that's less concerning than if it is really irregularly shaped. Also, there's a question of calcifications. These can be pinpoint calcifications. It can be almost like an egg surrounding like more of a cystic structure. Or it can be all of these little micro calcifications, which is most concerning for malignancy. And then at times you can also note lymphatic involvement and the presence of blood flow within the lesion itself. This here is a ultrasound image. You can see this is the actual nodule itself, and it is about 1.3 centimeters. It is about as tall as it is wide, and it is fairly, maybe a little bit hypoechoic, with no microcalcifications. We will look now at the TIRAD system. So this is the TIRAD system here. You have 5 different categories: composition, echogenicity, shape, margin, and echogenic foci, or I really like to think of that last one as calcifications. Each of the different answers to the category cause different points to be added up. So we could look at that last one and say that it was solid or possibly completely solid. It was possibly hypoechoic. Sometimes it's hard to tell if it's one or the other, and you just keep that in mind. You're looking at the scoring later. I would say 0 points for this because it is not taller than wide. It was round. It was smooth, so 0 there as well. And I would say no echogenic foci. So it was either a 4 or a 3. So we look here, and it is either mildly suspicious or moderately suspicious. And with these, you get more information. So if this was greater than 2.5 centimeters, then we would want to move on with fine needle aspiration. If we decided, well, let's go ahead and be safer and stick with the 4, then if it's greater than 1.5 centimeters, then we would want to do fine needle aspiration. If you remember, that one was 1.3. So instead, we could continue to do follow-up on this one, meet again later, ultrasound it again later, see if it's grown, if it's changed in characteristics, and if fine needle aspiration is warranted at that point, then move on appropriately. Fine needle aspiration itself is shown here. There are varying degrees of sterile technique that I saw used. The radiologists that I saw almost went as far as the OR. I'm exaggerating a little bit there, but they were really keen on keeping everything really sterile. The cytopathologist I worked with kept everything as sterile as you would assume someone would when they gave a intramuscular injection. And that was kind of his reasoning for why he did what he did. And so there are different degrees to which that is used. Also, while the cytopathologist I worked with, preferred to use the ultrasound on every case, and I think I would too, technically for very surface level nodules, you can just go by palpation. His reasoning, as well as mine, for using the ultrasound is the ultrasound tells you where you are, where things are, and you don't have to guess. If you look down here at this image, this is in the middle of a fine needle aspiration. This is that same mass that we had looked at previously. And if you can hallucinate this little kind of irregularity here, it's a little bit of a blur here. This is actually the needle coming in, just like you see up here, parallel to the probe. And because it's parallel, you can see the whole length of the needle. That allows, when you do this rapid to and fro movement, he's going to jab in and out and kind of slightly vary his angle just a little bit. Then you can make sure you're not getting down in the blood vessels that are right here. And it just winds up being a little bit safer in my mind. Maybe unnecessarily safe, but safer nonetheless. Ultimately, the sample is placed on a slide, fixed, and the slide is then evaluated under the microscope. So once cytology gets that specimen, whether radiology gives it to them or whether they're the ones that's actually taking the fine needle aspiration, there are a number of things that they're looking for under the microscope to tell them how to incorporate it into the Bethesda system, which I'll get into shortly, to be able to know what the diagnosis is and how to best manage the case. So the first question would be, is it an adequate specimen, which they define as greater than or equal to 6 groups of well-visualized follicular cells with greater than or equal to 10 per cluster. And you can see this here, there's really not much in cellularity here. This is likely from a cystic structure. This would be one that would be an inadequate specimen and would need an additional fine needle aspiration. The other question is, does it have nuclear atypia? This isn't just where it's just frankly horrendous, cancerous nuclei, but if you look at these, they don't quite look right. There's something wrong about them, and it does bring up a level of concern. There's also the question of cell crowding or follicular cells or microfollicle formation. These here are just all piled on top of each other. You see overlap of the nuclei here. It just looks like a heap of nuclei from all the cells being so tightly crowded together. And as you can see in this little inset here, there is microfollicle formation. I'm tempted to believe this might be the same thing here, but I don't know that's the case. But this is microfollicle formation here as well. Herthy cells are also a thing that needs to be investigated. Their presence can push in different directions diagnostically. And then finally, probably the most obvious one is suspicious for malignancy or clearly malignant cells under cytology definitely have an impact on the care of the patient and the management of their thyroid disease. This is the Bethesda system. So a lot of the things that we just talked about play right into this system here. If you don't have enough of the follicles, then okay, I need to repeat with ultrasound guidance to make sure that I'm actually in the nodule itself. Various times you can look and know that it's benign or atypia, follicular neoplasm, or you get into this suspicious for malignancy territory. And as you can see, as you go down, you have this increasing risk of malignancy, with the exception of the unsatisfactory test, of course. And finally, you have your management, what you want to do. Are you going to repeat the FNA? Are you going to follow up clinically and sonographically? There is molecular testing that can be done at times, which sometimes is covered by insurance and sometimes is not. And then when you need to, you have the option of going for lobectomies or near total or total thyroidectomies as well. So like that last column in there, it then moves on to management of the condition. This here to your right is a surgical excision of the thyroid. And it is one of those 5 possible recommendations. We can either repeat the procedure right now, do an FNA under ultrasound guidance. We can repeat the procedure later, follow up, and this would also include clinically following up, and then doing ultrasound, possibly leaning to fine needle aspiration later. We can get that molecular testing. We can move on to surgery of some sort, or when warranted, we can do nothing. And that is all included in that Bethesda system. So I want to take a few minutes now and look at one brief case, just to kind of get ourselves in the mindset of how this works, give ourselves a taste of this, and see how it goes. So like I said, this begins with the clinician. The history the clinician acquired. This is a 57-year-old female presenting with a neck mass, a midline neck mass. She complains of difficulty swallowing, coughing, and hoarseness upon interview. And she also told the clinician that the mass has slowly grown over years. The physical exam demonstrates multiple large non-tender nodules present on palpation on the thyroid, and the clinician who is astute and notices this is somewhat suspicious gets a TSH, which winds up being normal. But thankfully, this clinician still knows that despite the normal TSH, we now need to move on to sonography because this is a concerning presentation. There seems to be multiple masses that are slow growing, non-tender, and may very well be malignant. So it's looked at by an ultrasound tech or radiologist. We ask the question, and we're going to focus, I'll interrupt and say, we're going to focus on this one in the isthmus here. There are also other structures, other masses that have some degree of solid and some degree of cystic makeup, but we're focusing on this one in the isthmus, which is a little bit higher level than this one here. So the composition is, this is a mostly solid mass. You see some cystic structures. It is hypoechoic. This is darker than the parenchyma here. It is taller than it is wide. And if you look over at this side, there is Doppler flow within the lesion. All of these things are concerning. These here do make this a TI-RADS 5, 7 points or more. So we look at this, fine needle aspiration if greater than 1 centimeter. I don't have the numbers here, but I'm pretty sure this one was actually 2.8 centimeters. So this is going to need to get fine needle aspiration for additional diagnostic workup. So at this point, the cytologist gets the sample, or the sample is sent by radiology, and the cytologist looks at it under the microscope. In this particular case, there is very little colloid. There is moderate cellularity as well. And if you look, you have these repetitive microfollicles here, just scattered throughout. If you look closely, the nuclei are small and round. We don't have really irregular or irregular sized nuclei. They are right what they are. The diagnosis that would be able to be given by cytology would be that this is a follicular neoplasm. This cannot, under cytology, we cannot differentiate between follicular adenoma and follicular carcinoma. That would need to be done by surgical pathology later after the thyroid resection, which is what would be recommended given that 25 to 40% of follicular neoplasms can be malignant. So this patient would be referred to surgery, and the sample would very likely be examined afterward. There are additional cases. The ones that I found didn't incorporate the radiographic findings, but PathWeb Teacher's Thyroid Cytology 2 was actually really good, and I would highly recommend it if anyone is interested in learning more about some of these presentations under fine needle aspiration. I did use a number of resources. I didn't include up to date here, but I used it as well. But Path Outline and Radiopedia were tremendously helpful, and PathWeb Teacher really helped me to get my mind around some of the specifics. Thank you very much for watching. I hope that this was as enjoyable and interesting to you as it was to me. I find cytology to be really interesting and a heck of a field for anyone to enjoy, that really enjoys like the nitty-gritty, the real subtle findings, and the need for a new skill that very few people in medicine or outside of medicine have. So I hope you enjoyed.